This presentation is on physical examination skills and clinical diagnosis for the respiratory system. Before we begin the examination, let us review the different components which make up this system and how these function. The primary function of the respiratory system is gas exchange. Oxygen is taken into the bloodstream and carbon dioxide is eliminated. When assessing a patient for respiratory conditions, we need to bear in mind that it is more than just a pair of lungs. The respiratory tree starts from the nose and mouth and ends at the alveoli. The nasal passages are lined with mucous epithelium and hairs. Their purpose is to warm up the air which is inhaled, to moisten and to filter it. The nasopharynx, oropharynx and laryngopharynx is the cavity at the back of the mouth which extends from the back of the nose down to the larynx or voice box. Another function of the respiratory system is to facilitate in voice production. After the larynx, we find the first section of the tracheal ring structure known as the cricoid cartilage. The rest of the trachea descends anterior to the esophagus until it bifurcates into the left and right primary bronchus. Anteriorly, the division takes place behind the sternal angle. Posteriorly, the division takes place at the level of the fourth thoracic vertebra. The primary bronchi then pierce the parietal and visceral pleurae to enter the left and right lungs. There are successive divisions of the bronchi until the respiratory bronchioles enter the alveoli sacs. The blood supply to the lungs is by the left and right pulmonary arteries, and oxygenated blood is returned to the heart via the left and right pulmonary veins. In terms of nerve supply, the internal structures of the lungs are supplied by the parasympathetics from the vagus nerves and segmental sympathetic fibers. The pleural membranes and the intercostal muscles are supplied by segmental somatic efferent and afferent fibers from the thoracic region. The diaphragm is innervated by the phrenic nerve, which originates from C3, C4 and C5. It descends the neck, then through the mediastinum to pierce the diaphragm to supply it from its inferior surface. Lymphatic drainage is divided into superficial and deep plexi. They empty into the bronchopulmonary lymph nodes next to the bifurcation of the trachea, then into the bronchomediastinal lymph trunks. The right lung and left lower lobe drain into the right supraclavicular fossa. The left upper lobe and the stomach drain into the left supraclavicular fossa. Before you begin your formal assessment of the patient, have you noticed whether the patient was breathless when they walked into your practice? Do they need to break their sentences in order to take breaths? Have you noted any wheeze or stridor when taking their case history? Do they suffer from weight loss, a sign of serious pathology, or even perhaps weight gain from steroid use? Note too the presence of any surgical scars and inquire about them. Remember that assessment of the patient begins from the moment you meet and not just when you start your formal examination procedure. Mr. Peters, would you like to have a seat on the couch? I'll just go and wash my hands. Assessment of the respiratory system should begin with an inspection of the thorax. With the patient standing or sitting, view the chest wall from the front and the back. Note any deformities of the chest wall, such as barrel chest deformity, pigeon chest or pectus carinatum, funnel chest or pectus excavatum. A barrel chest deformity is caused by chronic obstructive airway diseases like chronic bronchitis and emphysema. It causes increased anteroposterior diameter. Pectus carinatum, or pigeon chest deformity, is often associated with spinal deformities, Marfan's syndrome, or other congenital deformities of the chest. Pectus excavatum, or sunken sternum, may be a long-term manifestation of asthma during childhood. It may also be associated with spinal deformities and is frequently seen in patients with Marfan's and Poland syndromes. Deformities of the rib cage are often associated with spinal deformities such as kyphosis or scoliosis. Kyphosis, or an anterior curvature of the spine, has a variety of causes, including trauma, developmental problems like Scheuermann's disease, and degenerative diseases such as osteoporosis. Scoliosis is a lateral curvature of the spine, and when significant, it takes the form of kyphoscoliosis. This deformity of the spine and rib cage may be idiopathic, of congenital origin, or it may develop as a result of pathological and degenerative processes. If you identify such deformities, note their extent and how these may be significant in compromising the breathing mechanics. Evaluation of these deformities are fully covered in the musculoskeletal presentation. Before you ask the patient to lie down, ensure that the couch is ready with clean linen or paper. Adjust the headrest to 45 degrees or use pillows to elevate their head. With the patient now undressed, form an impression of their overall state of health. Are they cyanosed in the face or their extremities? Are they panting for breath? Is the patient what we call a pink puffer or a blue bloater? Pink puffers are usually emphysema sufferers who are very dyspnoic and in their attempt to keep their blood gases normal exert a heroic effort. A blue bloater is associated with a degree of hypoxia, often seen with right-sided heart failure and chronic bronchitis. While the patient is lying down, note their breathing pattern. Note the breathing rate, depth, and regularity. Do this in an unsuspecting way, as patients may alter their breathing when conscious of being examined. A rate of 15 to 20 respirations per minute is considered as normal. While assessing their breathing, note whether the patient is primarily using the diaphragm or whether they are recruiting the accessory muscles of respiration like the sternocleidomastoid, the scalenes, and the intercostals. Alternating between long periods of no breathing and deep respirations is described as Cheyne-Stokes breathing. This pattern may indicate heart failure, uremia, or it may be drug-induced. It may also be seen in children and the elderly. Rapid, shallow breathing may be caused by restrictive lung disease and pleuritic chest pain. Rapid but deep breathing is seen in states of anxiety, metabolic acidosis, hypoxia, hypoglycemia, or it may be physiological after physical exertion. Slow breathing can be secondary to diabetic coma, increased intracranial pressure, and drug-induced respiratory depression. A breathing pattern, which is punctuated by frequent sighs, is often associated with states of stress and anxiety, and the patient may be displaying signs and symptoms of hyperventilation. They may complain of dyspnea, short breathlessness, and dizziness. Chronic hyperventilation may not have obvious presentations, but in acute hyperventilation, the patient may report pins and needles in the face and hands, tunnel vision, and may appear restless. There are many other immediate and long-term manifestations in this often underdiagnosed state. Is the patient suffering from cough? And if so, describe its type. Is it dry, irritant, or wet with evidence of expectoration? Does the cough have a so-called barking quality, or is it of a nervous or habitual nature? If the patient is bringing up mucus or sputum, then it is important that you examine it. Look for streaks of fresh blood which may be coming from irritated membranes in the throat. A pinky or frothy sputum may signify irritation deeper within the bronchial tree and the alveoli. With the patient now sitting on the examination couch, examine the key surface features associated with the respiratory system. It is advisable that you carry out the following parts of the physical examination from the right side of the patient. It is best that you establish physical contact with the patient by first examining their hands. Check for finger clapping deformities of the nails. Finger clapping is caused by a variety of conditions which are covered in detail under the general examination presentation. The respiratory causes of finger clapping includes bronchiectasis, for example from cystic fibrosis, empyema, cancer, pneumoconiosis, pulmonary abscess, chronic infections, and fibrosing alveolitis. Now inspect the face more closely. Examine the eyes and mucous membranes for evidence of anemia and central cyanosis. Central cyanosis is best examined in the mucous membranes of the lips and the conjunctiva of the eyes. Central cyanosis will signify either cardiac or respiratory anomaly. Respiratory conditions include pulmonary fibrosis or any other condition which leads to a serious limitation of airflow. Peripheral cyanosis may be observed in the exposed areas such as the tip of the nose and ears, the fingers and toes. It signifies poor perfusion to these tissues and is often seen in those with Raynaud's phenomenon. The next stage of the examination is palpation. Palpate the spinous processes for tenderness and deviation. Alternatively, briskly tap over the spinous processes for tenderness. Palpate the trachea to determine whether its position is central, and with one finger, gently feel its position at the sternum notch. The trachea may be displaced laterally. Fibrosis pulls the mediastinum towards the lesion. Similarly, a collapsed lung pulls the mediastinum towards the lesion. Pneumothorax pushes the mediastinal contents away from the lesion. Likewise, a large effusion will push the mediastinum away from the lesion. Next, we feel for the supraclavicular lymph nodes. Elevating the shoulders may assist you in the palpation of the supraclavicular fossa. Then place the flat of your hand on the left thoracic wall to feel for the apex beat. This is palpated at the fifth intercostal space in the mid-clavicular line. Enlargement of the heart causes a displacement of the apex beat. To locate the apex beat, we palpate in the fifth intercostal space in the mid-clavicular line. That is 2, 3, 4, 5. The mid-clavicular line would run down like so. And this is where we palpate for the apex beat. If you are unable to feel the apex beat, then you can get the patient to lean forward. Now let's assess chest expansion. Place your stretched out fingers over the chest wall with both thumbs just touching each other at the midline. Ask the patient to take a deep breath, ensuring that you allow your hands to move with the chest wall as they inspire. Assess whether the movement is symmetrical by looking how your thumbs move away from the midline. A reduced chest expansion on one or both sides signifies an underlying pathology. If this is unilateral, this may signify pleural effusion, pneumothorax, pneumonia, or a collapsed lung. If expansion is reduced bilaterally, then this may signify advanced lung fibrosis, severe airflow obstruction, or musculoskeletal problems such as ankylosing spondylitis. Now check for tactile vocal fremitus. Vocal fremitus is a transmission of vibration through the chest wall. Place the flat of your hands or their ulnar borders firmly on the chest wall and ask the patient to say out loud 99, 99, 99 or 111.
99, 99, 99. 99, 99, 99. 99, 99, 99.
And once more.
99, 99, 99.
Now lift up your arms for me. Hold them there. And again.
99, 99, 99.
Thank you. Put them down now. And the same.
99, 99, 99. 99, 99, 99.
The basic principle here is that the transmission of sound is increased in consolidation, such as lobar pneumonia, or when it contains a large cavity near the surface, as in a lung abscess. Vocal fremitus is decreased in those with soft voice, in obstructed bronchus, in chronic obstructive pulmonary disease, pleural effusion, fibrosis, pneumothorax, or an infiltrating tumor. A thick chest wall also causes reduced fremitus. The next stage is percussion. When percussing or auscultating, always attempt to visualize the underlying structures and in particular the anatomical divisions of the lungs and the position of the lobes. Remember that the posterior thoracic wall mostly overlies the lower lobes, whilst the anterior thoracic wall overlies the upper and middle lobes. With the index finger of one hand, strike the middle finger of the other hand just above the nail. Press your finger firmly on the patient's chest in the intercostal spaces. It is advisable not to let the other fingers touch the patient, as this will cause dampening of the vibrations. The movement of your percussing hand should be brisk and generated from the wrist. Your percussing hand should be relaxed and should bounce back immediately to prevent dampening of the vibrations. A thick chest wall, such as an obese patient, will require a heavier percussion than a thin one. Percuss in a systematic way by beginning from the top and work your way down. Compare side to side for variations in sounds transmitted. Percuss 3 to 5 places on the anterior thoracic wall. Start from above the clavicles and then directly percuss over the clavicles. Deviate laterally as you strike the lowest positions over the 7th intercostal spaces. The apices of the lungs are identified when percussing over the middle of the clavicles. Then percuss 2 to 4 positions laterally and about 5 positions posteriorly. When percussing the back, ask the patient to cross their arms to move the scapulae out of the way. When percussing the sides, ask the patient to place their hands over their neck to expose the sides. Reduced sounds or dullness may be found in the obese or with excessive muscle development. Dullness is also found in consolidated portions of the lung, as in lobar pneumonia and fibrosis, from tumors, and in pleural effusion. Hyperresonance and tympany is found in asthma, chronic obstructive pulmonary disease, in pneumothorax, or air-filled bulla. Dullness over the apex of the lungs may signify a Pancoast tumor or tuberculosis. The motion of the diaphragm can also be measured. Ask the patient to take a full breath, then fully exhale. Whilst in full exhalation, percuss down to T8. The resonant lung should be replaced with the dullness from below the diaphragm. Likewise, ask the patient to take a full breath and hold it in. Okay, deep breath in now and out, and just hold your breath. The descended diaphragm will indicate the shifted position from resonant to dull. Deep breath in and hold it in for me. Normal diaphragm exertion is expected to be at least 3 centimeters or more, but usually between 5 to 6 centimeters. Reduced diaphragmatic exertion is seen in unilateral paralysis of the phrenic nerve, with lung tumors, or a large effusion. The next phase of the respiratory examination is auscultation. We listen to the chest for normal breathing sounds over the bronchi and over the lungs. Also, try to listen for the presence of added sounds and determine whether these are heard during inspiration or expiration. Bronchial sounds are loud, relatively high in frequency, and dominant during the expiratory phase. The expiratory part is longer than inspiration. Bronchial sounds are normally heard over the central airways and near the mediastinum. Increased bronchial sounds indicate lung tissue consolidation, although the airways remain open, for example, consolidation due to pneumonia. Bronchial sounds are loud and high pitch. Inspiration and expiration may be heard equally, and there may be a small gap or a pause in between them. You can mimic this sound by placing your tongue on the roof of the mouth and breathe in and out through the open mouth. Vesicular sounds are transmitted over the lung tissues and their peripheries. They are softer and lower in frequency and can be heard over most of the lungs. You will hear them well in inspiration, but only the first part of expiration. Inspiration is therefore more dominant or lasts longer than expiration. There is no gap in between. Conditions which cause airway obstruction, such as asthma or emphysema, cause a reduction in vesicular breath sounds. Bronchovesicular sounds are normally heard anteriorly over the first and second interspaces and posteriorly between the scapulae. Bronchovesicular sounds have an equal inspiratory and expiratory phase. Tracheal sounds are loud and harsh. They are heard in the neck and over the trachea. Generally, reduced breath sounds may be due to effusion, pneumothorax, or collapsed lung. Crackles, crepitations, or rales are fine, non-continuous sounds produced relatively late during inspiration. You can simulate these sounds by rubbing a bunch of hair between your fingertips. These sounds are produced by the small airways if they contain fluids, as air is pushed through them. If the crepitations have a fine quality, it may signify heart failure or alveolitis. Medium crepitations are due to infections and coarse crepitations produced by larger bronchioles, as in bronchiectasis. Ask the patient to cough a couple of times to see if they clear. This would signify a bit of mucus being dislodged, such as those found in smokers. Wheezes are prolonged musical sounds and are produced by narrow bronchi. These are mostly produced on expiration. They are often heard in obstructive lung disease and especially in asthma and emphysema. Pleural rubs can be simulated by the friction of your fingertips when rubbed together. They are produced by pneumonia, pulmonary embolism, during the early stages of pleurisy, and are usually confined to the localized areas. It is sometimes possible to mistake pleural rubs with the sounds produced by the friction of the stethoscope against the skin or on a hairy chest. Start in a systematic way by listening to both lungs at successive levels and make a comparison. What I'm going to do is listen to your chest, but what I'd like you to do is to breathe in through your mouth, nice and gently. Okay, deep breath in. You should listen to at least 4 positions or levels anteriorly, 4 positions posteriorly, and 2 to 3 laterally. In addition to the above basic assessment of the respiratory system, there are several other assessment techniques and tests which can be added. Some of these include forced expiratory time and peak flow measurements, pectoriloquy, ergophony, combined auscultation percussion, and spirometry measurements. To view the demonstration on peak flow measurement, select this from the main menu. This concludes the assessment of the respiratory system. Let us now review the main steps. Observation. General assessment of the patient, the face and hands. Observation of the thoracic wall. Palpation of the trachea, lymph nodes, and apex of the heart. Assessment of chest expansion. Vocal fremitus, percussion, auscultation, and special tests.